There's perhaps no other medical specialty in which machines have played such an intrinsic part, almost from the very beginning, when the discovery of insulin was made by Banting and Best in 1922. 1921 they discovered, sorry about that. But, of course, the measurement of glucose was absolutely essential to the progress of treatment of diabetes. So what we've gathered here today is we have Chantal Mathieu and Pratik Choudhary from Leicester to talk about the role of machines in the field of diabetes. And we're talking a very wide range of machines, right from the kind of the glucose sensors and closed loop systems through to artificial intelligence and machine learning. So it is an extraordinary field, isn't it, diabetes, in the sense that it's always been so intimately associated with machines.
Yeah, it's very strange how you put it, because most of us became endocrinologists because we didn't like technical things, so we were no surgeons, and then within internal medicine we even shied away from gastroenterology or pneumology. So it is a bit strange how you say it, but indeed we are working more and more with devices, with machines, and the arrival of now algorithms, artificial intelligence, apps to support us in decision making, but also to support the people living with diabetes has exploded. So indeed, we have a lot of machines around us.
And that's true, isn't it? Right from the very start, because unless you could measure glucose and you needed to have some kind of device machine to do that, actually you couldn't treat diabetes effectively.
Yeah, talking to our patients who were there 50, 60, 70 years ago is always amazing when you hear that they had little labs at home to measure just glucose in their urine. So it was really quite technical from the beginning for them. Also their glass syringes, they needed to sterilize, etc. It demanded a lot of technique by the people living with diabetes themselves.
I was slightly horrified, Pratik, when I was doing something about the centenary of insulin to discover that at the very first, the people who were giving themselves insulin injections had to sharpen the needles every time they were used. I mean, just awful. But the development of machines has really been essential to developing self-care by the patient. I mean, what would you point to particularly as the exciting developments in this field, both in the recent past and now that you're seeing at EASD?
Thanks. I think the stepwise progression of technology has been really fast, hasn't it? And key touch points, I think, were in the 80s, development of insulin pens, where you moved away from people, cleaning their syringes and sharpening their needles. And at the same time, actually, the introduction of insulin pump therapy, which, of course, made such a huge difference to many. And then probably 20, 30 years after that, probably around about 2005 was when continuous glucose monitoring started to come in. And we moved away from kind of finger stick, people having meters. And actually, if I go back, it's the 80s. There was one big step in the 80s where we had pens and pumps on one side, and we had self-monitoring blood glucose meters on the other. And they were kind of big boxes that took 30 minutes. And now they've gone smaller and smaller, and we have machines that do it at much lower price in kind of 5 seconds. And then the next step was probably around about the 2005s when CGM came in. And then now we're on the cusp of the big transformation with the hybrid closed loops coming in. But to make a point, actually, to add to a point Chantal made earlier, I think the key difference between machines in diabetes versus machines in other specialties has been the interaction between the person living with the condition and the machine is unique in diabetes.
Yes.
In cardiology or pneumology or gastroenterology that Chantal mentioned, it's a tool that the doctor uses. But here it's almost more of a consumer device.
Yes.
Because the person has to interact with it so frequently.
Yeah, that's absolutely right, isn't it? It's always been used by the patient. And actually, again, I'm sorry to keep harping on about the centenary of insulin, but actually, it was an extraordinary medical discovery because that was the first time that actually management of a condition was really put into a patient's hands. And it stayed like that. And actually, machines have made that possible.
Absolutely. And I can tell you, many of our colleagues find it amazing when we tell them, you know, this woman is going into labor, she's in control of her glucose. So for the gynecologist, the anesthetist, it's very often a threat that we don't give them a very strict prescription of do this or that, but that we say, you know, let the woman do it. She knows how to do this. And it is really a very specific disease where this is happening.
Let's talk about the new generation of equipment coming towards us now. What are your thoughts on that?
Oh, I think Pratik will agree with me. It is the new revolution, the arrival now of intelligent systems where you have what we call hybrid closed-loop systems, where we have insulin pumps, sensors, and algorithms being integrated, really helping people to, especially people with type 1 diabetes at the moment, to have amazing glycemic control, avoiding not only hyperglycemia but also hypoglycemia and having much more stable glycemic control. So that is really a revolution now.
And you see the value of those sort of machines or equipment in that it allows elite athletes with type 1 diabetes to compete in endurance sports, to compete at Olympic level. I mean, just think of somebody like Steve Redgrave, with a 5 times gold medal winner, doing extraordinary feats of endurance in a small boat, but only because of this new equipment. I mean, it's amazing.
But what is fantastic, and Pratik can say more about this than I can, is that it was people living with diabetes who pushed forward the technology. We had pumps, we had sensors, but closing the loop, or almost closing the loop, and putting in performant algorithms, industry was quite hesitant. And so what pushed the field forward was people with diabetes hacking the system and saying, you know, we're not waiting any longer. That was the terminology of Night Scout, but they pushed the system, and then industry followed. But it was amazing, Pratik. It was really they who pushed the system. Huh?
And it was, absolutely right. And it was an amazing patient power, right? I don't think there's any other speciality where that's happened so important. And I think the key thing, Vivienne, you mentioned the kind of elite athletes, but for me, but they're always so hugely motivated. They found ways to do that. What really affects me in a sense is that it's the average person living with diabetes just trying to get by with what is actually one of the toughest conditions to live with long term. And I think the key differentiator for me is that up till now, you know, we talked about the early days when you had kind of one injection and people would have these little labs in the house. And then we moved to kind of the 80s and we told people, you've got to measure your glucose 4 times a day and inject 4 times a day. And then we got to the 2000s and we said, you've got to have a CGM that measures your glucose and you've got to look at it 15 times a day and bolus 6 to 8 times a day. And, you know, we ask people to work harder and you get better results. And that's something, you know, we all understand in work, in academic, in studies, you work harder, you get better results. But these technologies are unique because what they're doing is they're separating out. They're saying, actually, we're going to let you work less and you're going to get better results. And that's that dissociation between having to work and spend a lot of mind, intellectual and emotional energy on your diabetes to get the results you need. That's what the key benefit of technology has been. It's freeing up people's minds and emotions from their diabetes and getting better results.
And you talked about type 1 diabetes, but what's in the offing for people with type 2 diabetes? Pratik.
It was, So I think you know, type 2 diabetes is really interesting because, of course, recent data from France showed that simple technology, Freestyle Libre, had a massive impact on reduction of acute admissions and improvement in glucose control at the national level. And these are showing that within type 2 diabetes, I think it's such a heterogeneous condition. There is a significant proportion of people with type 2 diabetes where they are insulin deficient, where these technologies, the biggest RCT of pump therapy was in insulin-treated type 2s, showing big benefits. So there's benefits of pumps, there's benefits of sensors. The data from the recent Tandem, one of the closed loop systems, showed that in type 2s, they were equally effective. Maybe we'll get away from this kind of differentiation and we'll treat, where there's a glucose problem, we'll treat it with the best technology available. Where there's a cardiovascular risk problem, we'll treat it with that. So I think we will see an increasing push of these technologies and appreciation that actually wherever glucose control is a major issue, these technologies are able to manage that very effectively.
Now, many of these systems come with accompanying apps. And in one sense, those apps are enormously helpful because they allow people to share information with other people living with diabetes, and that's very helpful if they're all thinking about their exercise or their step counting and all those kind of things. But there are also some downsides, aren't there, to that, Chantal?
When you said apps and sharing information, I started sweating already because it's a very thin line to walk. When you want to use sensors and the apps that go with the system to upload your data, etc., you need to read 3 pages of disclaimers.
Just
and then
3.
Well, and then at the bottom there's a box, I agree with all, cross here and then sign. But you need to do it to be able to use the system. So it is becoming, I can tell you, in my country, for instance, we need contracts with all of these companies, with all of the softwares. We need to have agreement, and it's a GDPR nightmare because when you sign, you of course allow your data to be shared not only with your loved ones, for instance, but also with companies. What do they do with that? And so, yes, of course, they use it to train the system, to make it better, blah-de-blah-de, but everybody gets a bit nervous. So we are living exciting times where it becomes a learning curve on where do we go with sharing the data, who owns the data. It's a discussion we're having here at EASD very frequently. But it becomes interesting because you can share data, learn with other people, but it also becomes quite a GDPR nightmare sometimes.
And that is an issue. Not everybody plays by the rules, do they, Pratik?
No, yeah, and so I think there's 3 issues actually with the data. I think the first part is that the patient is now confronted with, the person living with diabetes is confronted with so much information that can prove overwhelming, and we have to adapt our education, our information that we provide people so that they can use that data effectively. The second impact is on the healthcare teams. We're now having data-driven consultations, and we recognize that suddenly it feels like our eyes are open, we know what's happening, and the quality of advice we can give increases exponentially. But I think we're only harnessing a fraction of what we can do with the data we have through apps and sensors and devices. Because once that data, if you can solve the issues of interoperability, if you can get the data into central warehouses and solve the, make it anonymous, make sure it's data going through, actually what we can do with the data is way more. We had a big session on artificial intelligence, and once the big data is there, it can take even more of the thinking out of the realms of the person with diabetes and the healthcare professional. And for many people, it can kind of, help us. What we want to know, Chantal, isn't it, is that of our 3,000 patients, who are the people who are struggling the most? How can we put most of our time to those people, and the people who are doing well and will get a little bit of support from the AI and from the technology, we can be a little bit more, let them get on with things if they need to. And that's the real power of data as it comes through with these devices. And I think that's what we're going to see in the next 3, 4, 5 years.
Yeah, and it's interesting, isn't it? I'm glad you mentioned big data because there is vast amounts, petabytes of information coming in from all these devices, and you in your clinic in Leicester can't really look through it. You need AI to extract the patterns from that data, and we're seeing AI being used more and more often. And actually, I suspect that what AI will do is not only do exactly what you say, Pratik, is give us an insight into those patients who are struggling or are most in need of help, but also it might begin to open up new research questions.
For sure. And, you know, what we have been doing, many of us have been doing in how we accompany our patients was pattern recognition, for instance, of glucose curves. Pattern recognition of what is the person doing, what is he exercising, etc. That now is being done by algorithms, by artificial intelligence. But as you say, I think when we look back 5 years from now, we will think, they were playing in kindergarten. Because this is where a lot of research is happening and where really performance is improving. And in the end, it's all about reducing the burden for the person living with diabetes using these systems. But I think Pratik will agree, it's also about reducing the burden for the healthcare teams, because then we don't have to do all this pattern recognition anymore, but we can focus, for instance, on motivating the person living with diabetes to adhere to therapies, to exercise, etc. Or we can keep our eyes open on complications, for instance. So it's a very interesting field where everybody will benefit. And
it's interesting, Pratik, isn't it? Because during COVID, we saw everything having to be done digitally, and suddenly, you know, something that would have normally taken perhaps a decade to achieve happened kind of almost overnight. So you've got people using those digital solutions quite well, but you've also got people who really need the face-to-face time. And actually, I think that what AI may do is help us decide which are the people that really need that face-to-face time, whereas the other people don't have to schlep in to have a routine visit when all you say at the end of the visit is, it's all okay, just carry on doing what you're doing. That's a kind of a waste of everybody's time. But actually, AI may be the way that you avoid that.
I think that's so important. And I think a lot of the conversation has ended up being quite polarized. Oh, we must go back to face-to-face. Or certainly in the UK, we've got a lot of media attention about you know, everything's going to be virtual. And the reality, of course, is something in between. And actually, the most important person choosing how that follow-up should be is actually not the AI, it's the person living with diabetes. And I've always felt that we need to see the right person at the right time in the right modality. And what AI will do, though, is it will help us identify those people struggling, but it will also hopefully help us organize our healthcare a little bit better so we can manage our capacity a little bit better. We're already talking about using patient-initiated follow-up, monitoring things. And it comes back to the point, doesn't it, that there's an oft-used slide. I mean, how many minutes does someone spend with their healthcare professional compared to the number of minutes which they live with diabetes and they have to make decisions at their time? So we'll always be in a minority with the time we spend, and we've got to use it very effectively. But the patient will have a say in that choice, as will the data.
But it is interesting, this idea of AI coming up with new research questions.
Yeah, and again, we've been very glucose-centric in our discussion till now, but as you say, research, for instance, on movement detection, research on recognition of carbs or fat or protein on your plate. It's amazing what is happening out there, and seeing that being translated already now, again, in probably rudimentary applications. I'm sure in 5 years it will be completely different. But so research there is amazing, and it's indeed about more than just glucose. And then I mean, think of the Camillo Golgi lecture by Guido Heerspink, where he talked about recognizing individuals who may best benefit a specific treatment. He was talking, for instance, about SGLT2 inhibitors and the kidney. Also there, a lot of research is happening on how to recognize, on the basis of biomarkers, clinical features, therapies that will be best suited for a specific individual. So it's not only in our trade, glucose monitoring and insulin application, it's also about exercise prediction, it's also about food prediction, but also on what therapy is best for what patient.
I'm very conscious of the fact that, so in the UK, the AI was being used for retinal scans being done at Moorfields Eye Hospital. And actually, yes, it was very good at the retinal scanning, but you might also start to get, because the optic nerve is a kind of window to the brain, you might also start to get information about, for instance, Alzheimer's or all sorts of other conditions as well. So actually this huge amount of data being sorted by AI can come up with completely new and novel directions for future research and treatments. Pratik.
It's an amazing field, and absolutely, you're right. Once you've got the data and you've got this kind of 360 view of the person, then you can start finding those little associations in the data that you weren't aware of. And the biggest, and as you say, we get research questions. Once you've got data on, now we've got data with closed loops, for example, on insulin delivery, on meal times, on glucose variability. We can start seeing how those things impact on, again, on healthcare utilization and on long-term complications. I think the biggest challenge to some of the things you're talking about is the fact that at the moment, all these data sit in different silos.
Yeah.
So we've got a silo of data that's with the patient. How am I feeling today? What's my fear of hypo? Have I had a DKA? We've got data that sits with the companies that Chantal was talking about, sitting from their glucose monitors and meters and pumps. We've got data in our hospital systems, which are telling us about their path, about their labs and what we did when we saw them. And we've got data sitting in primary care networks and kind of the general National Health Service, which is, when my patient saw the orthopedic surgeon or the ophthalmic person or the, for the unrelated chest issue. And if we really want to answer the sort of questions, Vivienne, that you're talking about, we need to find a way to combine that data, but staying within the kind of data sharing and making sure it's used in the right way.
I have a feeling, Chantal, that you talked about patient push for these combined machines. I think you'll see patient push to make sure that data sets are combined, because their view is, this is data. I want you to use it because I want people like me to get a better treatment. Although I do think, and I don't know whether you'll agree, Pratik, that some people are quite spooked by the kind of information that can be held.
Yeah, exactly. Everything will be about education or communication, what is happening with data. Because, we all watch science fiction movies where, in the year X and X, they will come and control what we're eating. I don't know who they will be, but that is in the mind already of people. When you use my data, you will... When I explain, for instance, a motion tracking device coming into pumps and sensors, people will say, ooh, then you will know where I go and where I eat, etc. Yes, but only to help you. But so explaining that and safeguarding for what the information is being used will be of the utmost importance. But indeed, people are willing to share data. People are willing to share samples. Think of all our research on biomarkers in type 1 diabetes, for instance. People are generous and demand that we do something with these samples and these data. So they will also push it, but we will have to clearly explain what we want to do with these data.
Now, the terrible thing, Chantal, if it was little green men, we wouldn't see them. So we are sitting in a green screen studio surrounded by green. So if it was little green men, they could all be here. We wouldn't know. Pratik, finish us off. We're just coming to the end now. What are your hopes for the future in terms of machines and diabetes?
The point, so there's a saying, there was a kind of a French diabetologist called Gerard Riac, who I had the pleasure of doing some talks with. And he made a comment once in a lecture, and I borrowed his slide, which is that asking, with diabetes, you have tasks that you have to do again and again and again. And the fact that someone doesn't do them doesn't mean that they're not intelligent or clever enough to do them day by day. You can calculate your carbs, measure your glucose, and work out your proper insulin dose. But the point about diabetes is that you have to do it again and again for the rest of your life. And it's these repetitive actions that machines are good at. And so I think we're now at the cusp of, let's give the machines the tasks that they were built for and allow people with diabetes to get on with living their life to their fullest. And that's where machines need to go. That's where the artificial intelligence needs to go.
Yeah.
Fantastic. Pratik Choudhary, you've just rounded it off beautifully. Yeah. Chantal, Mathieu, thank you so much. And that's the end of discussion, which actually could have gone for a much longer time. It's such an interesting area. There's more to come.